Hello, good evening. Today I want to talk about the use of language and the power of language when it comes to psychiatric care and the medical establishment. My name is Amanda, and I'm an aspiring health coach. I want to help people get off and stay off psychiatric medications and achieve optimum health in the absence of them. I myself am a psychiatric survivor. I've endeavored to learn as much as I can about the psychiatric industry um, on a personal level, but now I have a professional reason to do so. So I have just finished reading this book, Clinical Psychopharmacology Made Ridiculously Simple. It's a short Cliff's Notes version of more advanced curriculums. It outlines the common treatments for common psychiatric disorders. It shows decision trees that prescribers use to choose medications, and it talks about key points for them to communicate to patients when prescribing these medications and some of the difficulties that might arise, as well as contraindications, underlying medical conditions that may cause the disorders, and things like that. So this was an important book for me to read because it helped me understand the thought processes behind what has become an all too common phenomenon, where we reach for psychiatric medications and pharmaceutical solutions to negative states of feeling that we're calling symptoms, recurring patterns of them. And because it is just about the prescribing of medications, it's very reductive. It doesn't talk about potential first line of defense, except to say in many cases that exercise is a highly successful intervention, although it does not prioritize that as a first measure. It just says doctors may mention exercise is effective in treating certain conditions, such as anxiety or depression. I want to open with a story from my life. When I was about 25 or 26 and had already been diagnosed with bipolar disorder and had already been compliant and taking medications for that for about 4 or 5 years, I attended a lecture. The guest speaker at this lecture was a psychiatrist. The lecture was organized by NAMI, the National Alliance for the Mentally Ill. They provide a lot of support groups for what they call consumers. If you're a psychiatric patient, that is the term, consumers. It was interesting to me that they use that term and continue to use that term. This lecture was open to both consumers and their families, so I attended with my maternal grandmother. And the psychiatrist, when discussing bipolar disorder, informed everyone that they were creating a third category in bipolar disorder. There are two subtypes, bipolar 1 and bipolar 2. Depending on the severity and duration of your mania, you will have either bipolar 1 or bipolar 2. The psychiatrist said that they had created bipolar 3 because there were so many people who had been prescribed antidepressants as children or adolescents. And in their developing brains, the antidepressants caused mania. Not only did this occur when they were taking the antidepressants, but it was believed that the antidepressants permanently altered their brains such that they would have mania throughout their lives if it was untreated. And I recalled that my first experience of mania was after I had been put on Prozac when I was 16. Um, I was not only put on it when my brain was still developing, but I was a very late bloomer for other reasons. I didn't even experience puberty. I didn't get my period until I was 16. So I remember it having a very powerful effect. I remember it triggering mania and me not being able to deal with it because I didn't understand what was happening to me. I had racing thoughts, paranoia, abundance of jittery creative output, became disorganized, hyperactive, sensitive to the sun, and wasn't thinking clearly. I also recall really regressing and behaving in ways that were not age appropriate. And I recall confronting my psychiatrist with this and him saying, I'm going to up your dosage, and me freaking out because that didn't at all seem like something I could handle. I couldn't continue like that. So that was my first experience with taking psychiatric medications, and I later in life developed mania. A few years later, it hit me really hard. Now, during this lecture, after he presented this information, I remember no one having really much to say about it. People were grateful to him. He was the expert, he was the authority in the room. I raised my hand and I said, so if a person has bipolar 3, what is the go-to line of treatment for them? And the psychiatrist said, oh, well, they are treated with the same meds as bipolar 1 and bipolar 2, and it is for the rest of their lives. And no one batted an eye. So, keeping that story in mind, I'm going to read to you from Passage on Bipolar Disorder in Clinical Psychopharmacology. And in this book, they do talk about how we know now that antidepressants can induce mania. Usually, what happens is that if antidepressants induce mania in an adolescent or an adult, the psychiatrist will say that that person always was bipolar, they just didn't recognize it. The most common time for someone to go seek psychiatric medication is when they are depressed. So many people, they say, actually have bipolar disorder, but don't recognize the mania, only the depression. because depression is what hurts and that's what they want help with. If there isn't a basis of history, then the psychiatrists have absolved themselves of misdiagnosing people by saying, well, it was always bipolar disorder, and we figured that out because the patient had this reaction to an antidepressant. However, the whistleblowers that I've been talking about in previous videos, such as Peter Goetsch and Robert Whitaker, have done some analysis of how these drugs are created and marketed. And it is their opinion that the antidepressants do cause mania as an adverse side effect, and that the industry, the pharmaceutical companies, are trying to eschew accountability for that. And in that moment, I certainly felt cut to the quick because I recognized immediately this person is saying that these doctors created brain damage in a huge swath of young people, patients, permanently, and the reward for doing that for them is exponential payoff in the form of lifelong continued treatment and dependence on the very same medications that made these people sick in the first place. My own life story, because it has so much to do with picking apart my symptomology from early childhood trauma and abuse. It took me a long time to find a way to articulate what had happened to me. It took me a long time to separate the idea that I was a broken, mentally ill, defective person, and that it wasn't just luck of the draw, genetics, and to look at what happened to me as a child as a potential causal factor, and to distinguish between mental illness and mental injury. And that is the power of language. And I'm going to later make a video exploring the question of whether trauma-informed care is industry CYA, because it seemed to me that it was a long time in us even getting to the point where we could posit social factors as causal factors in the epidemic of mental illness in America. And then once trauma-informed care was on the scene, it seemed to dominate and explode in popularity. And I was happy about that, but also leery, very leery. So as I read this paragraph to you from clinical psychopharmacology, I want you to think about the use of language, and I specifically want you to focus in on the use of the word appropriate here. Okay. Treatment of bipolar disorders has two goals. The first goal is the reduction of current symptoms, and the second is the prevention of relapse. Bipolar disorders are invariably recurring, and thus prophylactic treatment is warranted. Although prevention of episode recurrence is a goal, in reality, only about 1 in 5 will, with appropriate treatment, avoid subsequent episodes. The more common outcome is that appropriate treatment can significantly reduce the number and frequency of episodes. Unfortunately, even more common is that patients are non-compliant with medication treatment, typically owing to side effects, and the result is ongoing recurrences. Strong evidence indicates that failure to continue treatment can lead, and often does, not only to relapse, but to a progressively worsening condition. Subsequent episodes tend to become more and more severe and can at times become treatment refractory. What is this paragraph really saying? 1 in 5. That is your shot. You have a 20% chance of the medications actually preventing what they say they are supposed to prevent. And even though your odds of actually treating your condition and preventing further episodes is so low, they are so low, your choice not to continue to take them is non-compliance. And your disease will get worse with time. This is a lie. Your disease will not get worse with time. Your disease will get worse or better depending on your overall physical health and your lifestyle. What this paragraph is saying is that the treatments failed, but it is not really saying that outright. And that is the problem with a lot of the medical literature on these medications. There is also a heavy amount of blame leveled at patients for their non-compliance. I wanted to become a health coach to target people like myself, to help them understand a few things. In thinking about how to craft a health and wellness plan for anyone who is coming off of psychiatric medications or has taken them and doesn't want to take them again, I came up with 10 steps, and then I thought, no, there's one more, and it's the first one because it's the most important one. And that is to believe that you can get well, 100% cured. One of the major points of indoctrination foisted on psychiatric patients is the line that what's wrong with you has no cure. There is no cure for it, and it is chronic. There's only treatment. If you believe that, then it's true. Where I feel for myself is that when I was diagnosed, I was so young and so uneducated in these matters that I didn't have the wherewithal back then to say, well, then I demand a cure. I would prefer a cure. Please come up with one. It was almost as though there were all these other medical conditions that we were fighting, and you would see all of these race for the cure, right? Breast cancer or MS, these terrible life-threatening diseases. And it was like my disease is not cancer. My disease is not a crippling degenerative disease, although that is actually kind of how it's portrayed by the psychiatrists. It's a crippling degenerative, progressively worsening condition. And it was like we didn't deserve that level of analysis or research. We didn't deserve to be able to stand up and say, let's find a cure then. You're the ones raking in billions of dollars a year. Get to work. I challenge you then to find a better way. It's like we didn't deserve it. So I made a previous video about when I came off meds, and I think I will call that video, I didn't buck the system bucked me. And in thinking about who do I want to reach, how do I want to help people, I have noticed that although there was a lot of suffering and pain in being a psychiatric patient, I think I've been thinking about that as different somehow from other medical illnesses and other medical problems. I've noticed that there are an incredible number of people presenting with chronic illnesses for which the medical establishment has no known cause and no known cure. They're also, like my psychiatric illnesses, persistent but not life-threatening, life-limiting, obnoxious, painful, but not terminal. And it seems to me that a lot of younger and younger people are presenting with these illnesses and that they're seeking help and guidance. Things like PCOS, ulcerative colitis, PMDD, arthritis, IBS, psoriasis. I don't know that that's not a known, there's no known cause or cure, but it just seems to me that more and more in my personal life, people will tell me that they have something and I'll look it up. And in the articles about it, it will say there is no known cause. There is no known cure, but there are treatments. The same line that I was given about my bipolar disorder. If you can't tell me what causes it, how can I trust that what you're going to treat it with will do the job? And so I think people end up in a state of frustration, and that is part of what, hopefully, as a health coach, I can help them deal with. I want us to think about what is the difference, let's talk about language, between saying there is no specific cause, there is no known specific cause, the specific cause of this disorder, disease, malady, or condition is as yet unknown, and finally, we do not know what causes X, Y, and Z. Only in the last statement is there agency. The last statement is the only one in active voice. And as far as I can see, until we start demanding an active voice from our healthcare providers and until we have active voices in our healthcare, a lot of us will continue to be, say, compliant sufferers. Is that the best we can hope for? I don't think it is. One of the books that I read, I think it was this one, Peter Goach, Mental Health Survival Kit, and Withdrawal from Psychiatric Drugs. This is from a doctor himself. I think this is a quote from that book. Healthcare is not about logic. It is about power. There's incredible power in the way that we talk about things. And I've been able to identify at least 6 different types of psychiatric survivors. One type is a person who had trauma and abuse in their background, but was misdiagnosed because the symptoms were not connected in the mind of the treating physician to trauma and abuse, because so little was known about the long-term neurological effects of such. That's really just one of 6 types of people who get captured by the psychiatric industry